Hello, hello, hello. Hello, everyone. How are you? Talk to me. Let me know if you can hear me. Hi, Miss Haley. Hi, Nurhan, Stacy. I believe that's you, Miss Mills. Let me know if you can hear me. This is my sound check. Hi, Gail in process. Awesome, awesome. All right. So we have a lot to unpack. And yes, I have not been staying within the confines of the 30 minutes because this is the AMCI 30/30. You're going to get 30 minutes of instruction, I hope, and you'll have 30 minutes to ask questions. All right. Thank you, Stacy. Hi, Matthias. Hi, Tasha. Hi, Michelle. Hi, Vina D. Missed you. Ada, how are you? Okay, I'm going to get started. All right, so today we are going to talk about emergency departments. We're coding for the facility, right? But before we go any further, I want to say hello to my team. I saw Miss Haley, I saw Miss Mills, and if anyone else comes through, I'm going to say hello to you. Hi, Miss Brenda. Hi, Lily Mae. Hi, Fanny. Let's get started. Oh, don't forget to like this session. If this is your first time attending, and some of you do look, like I may not recognize you, so it may be your first time. Just want to let you know there is a disclaimer, and this disclaimer is that there's an expectation, or we expect you to kind of know some stuff. You have to be pretty proficient with ICD-10-CM. In other words, you should have completed part 2 in your course. Also, you should have an understanding of CPT guidelines. So you probably should be somewhere close to finishing part 3 and HCPCS level 2. So you should know those 3 code sets. If you're an MCD student, you should be in part 3 or beyond. If you're an a la carte student, you should be in part 3 and beyond. In other words, you should have already completed parts 1 and 2 of the course. If you are a YouTube student, you should have completed at least the first 12 weeks of the YouTube course, right? Okay. Now, let's go ahead and let's read the copyright. CPT is copyright of AMA. All rights are reserved. Keyword concept, FTR, Chun, AMCI Fab 7, AMCI ICD-10-CM Flip Tap, and MCG are registered trademarks of AMCI. The CPC, CRC, COC, CPMA, CPB, CPPM, CPCO, and more are owned by AAPC. CCA, CCS, CCSP, RHIA, RHIT, and more are owned by AHIMA, and AMCI does not own the rights to these credentials. Okay, coders, the goals of this presentation are pretty much the goals from last time, but we are going to do some stuff a little differently today. We're going to review an ED record. We're going to code the emergency department using the ED acuity points system. We are going to do an E&M review, not because we have to code for E&M for a facility, but you do need to know the medical decision making in order to get the facility code. I know, I don't make these things up, but you got to know E&M. We're going to do some practical application, and we're going to take a look at a UBO4 form. If you know what a UBO4 form is in billing, type it in the chat. Let me know what you know. Hi, Britters. Hi, Shantae. I read your review. Thank you for your survey response. Yes, we read those response, and you know what? If you don't mind me telling them, Miss Shantae said she's here for it. Bring it on. Outstanding. All right. So, do you know what a UB04 is? I want to know what you know. Okay. Somebody said they do. They learn to fill those out back in college. Yes, that is the claim form. Back in the old days, I'm not saying you're old, but I am, we used to have to use those forms and we used to have to manually build. Now they are integrated in the EMR or EHR, electronic medical record. And in the old days, that exact form used to be called UB82. Now it's UB04, and that represents the date that it was refined. Okay, so every time they republish it, it gets that date. All right. Yes, it's a hospital claim form. All right, let's get started. So I got my sound check out of the way. Thank you all so much for engaging. Last week, we learned more about ED facility reports. This week, we're going to do more, but for the people that are new, I'm going to review very quickly just to let you know when you're coding for emergency departments, you're coding for the facility, right? The facility. That means you're not coding for this provider or professional. No, you're coding for the facility. And what is the difference? We use time or medical decision making for the code selection for the provider or evaluation and management codes for the provider, but for the facility, we have to use a system involving acuity points for the emergency department or the facility. All right. And one thing that is interesting, when you code for the professionals, you do use these CPT codes, and we do determine the level of the medic or the level of visit or medical decision making or the code by scoring, right? And you're either going to have a minimal level, a straightforward level, a low, a moderate, or a high level, right? And that's the same for the facility. You can have these levels, however, they are not one and the same. Your MDM score, your E&M, we'll just say E&M, your E&M level is not the same as your ED level, right? And just so you have it, this is a glimpse of the AMCI ED acuity chart. And what is an acuity chart? It's these are pretty much guidance or guidelines that CMS has kind of established that you're going to base your encounters and develop or acquire your code. So CMS comes up with these guidelines and they pretty much leave it up to individuals to determine how they're going to set up their chart. So this chart was developed by AMCI in accordance with CMS, AMA, and ACEP. Now, CMS gave us the framework for how hospitals should report these facilities, but they left up to us to come up with the chart. Now, our chart is very much in sync with AHIMA's chart. So if you take the AHIMA exam, they're going to give you, and I'm talking about the CCS exam, they're going to give you their acuity chart. But in the real world, if you do any kind of coding for the real world or you're doing a pre-hire exam, they might ask you which acuity chart did you use. You may use this one. As long as your answer is consistent with this chart, you're good. All right. So that's what this acuity chart does. It measures the number of medicines, the degree of the MDM, like the E&M code, the number of tests ordered, and don't you split panels, remember that, and the number of supplies used. Now, I'm getting right into it. We're going to do our homework review. Now, last time we said, wait a minute, I want to make sure you can see. Okay, so last time we said, hey, this is a UBO4. And this week we are going to score. Well, no, first we're going to code out our scenario. Then we're going to take our scenario and place it on the UBO4. All right, coders, I can't do this. I couldn't do it all, but we still have a really good presentation because it's a little hard to do, you know, but you'll get the picture. I think I did an okay job. All right, so this is a UBO4. We're going to code out our scenario and we're going to place our scenario on a UBO4 and we're going to learn about that UBO4. All right, and then I'm going to give you 30 minutes to do your thing. All right, so for the people that haven't been here before, this is how you code out an encounter. This is how you code a facility encounter. Number one, you're going to determine the first listed diagnosis. Number two, the secondary or additional diagnoses. Number three, determine the procedures. Number four, determine the E&M MDM, so the E&M code, right? The doctor's code. And use, after number five, after that, you're going to use the chart to determine the ED facility level of service. So it's 5 steps. And when you're taking your CCS exam, you're going to have a multiple select exam. But I decided that we are going to code this completely out, and I want you active in the chat. I want to know what items should be coded. So this is, we're going to do the multiple choice thing, right? But I also want you to show me or tell me what should be coded, because if it's multiple select, you get to only select from the choices that you have. But in the real world, they're going to ask you to code it on out. So let's get into it. All right, so we're going to code it out. Here is our scenario. We've got Marcus Green, medical record 456789112, date of service 8/31/2025. Attending provider, Dr. Alicia Monroe. Chief complaint, chest pain. History of present illness. Mr. Green, 58-year-old male presenting with sudden substernal chest pain. I'm back. Oh, there it is. Okay. Um, okay. I'll just start from the history of present illness. The history of present illness is what the patient is saying about their illness, the history of the present illness. Mr. Green is a 58-year-old male presenting with sudden substernal chest pain radiating to his left arm. Pain began 1 hour prior to arrival, associated with nausea, diaphoresis, and shortness of breath. Past medical history: hypertension, hyperlipidemia, type 2 diabetes mellitus, former smoker, quit 5 years ago, diagnostic tests ordered, EKG, stat. When you see stat, that means right away. Cardiac enzymes, troponin CK-MB. CBC, and that's a complete blood count, and CMP, a comprehensive metabolic panel, chest x-ray, ED course, EK, EKG, ST segment elevation and anterior leads. Interventions: aspirin, 325 milligrams, nitroglycerin, SL, oxygen via NC, IV fluids, cardiac monitoring, cardiology consult, and the consult resulted in cath lab activated. So they decided that this patient is going to the cath lab. Patient was stabilized for transfer. Final impression: acute anterior wall STEMI, hypertension, hyperlipidemia, type 2 diabetes mellitus, comorbidities, disposition, admitted emergently for cardiac catheterization, and it was authenticated. Okay, coders, first question: is this chart properly authenticated? Yes, absolutely. Absolutely. Good job. Good job. Good job. It is at least at minimum first, last name, credential, and date. Outstanding. All right, now coders, we got to code this. Making sure I am not giving anything away. If you want it, the first question is going to be, what is the first listed code? So go ahead. You know what? I'm just going to do this, and then we'll do the first listed code. All right. Hmm. And remember, we're coding for the facility. All right. So go ahead and write in the chat the first listed code. And then on the next slide, I will add my inventory. Okay, people are starting to answer. What do you think the first listed code? What is the definition of first listed? Well, that's the chief reason for the encounter. Now, this is outpatient, right? So, outpatient has a different definition. An outpatient first listed has a different definition than principal. We're only dealing with first listed. This is the chief reason for the encounter. In other words, which diagnosis was chiefly treated. And you all are rocking it, rocking it, rocking it. All right. So, what is the first listed code? Well, this is what I'm going to do. This is what I would do, right? I would write down all diagnoses, signs, and symptoms because you got to know what you're going to select from. Well, from and if you can, do it in order. So, substernal chest pain, that's the very first diagnosis, sign, or symptom provided, and it's radiating. Nausea, diaphoresis, shortness of breath, hypertension, hyperlipidemia, type 2 diabetes mellitus, history of smoking, and acute anterior wall STEMI. And when we say STEMI, that is ST elevation myocardial infarction. So anytime you see STEMI, you know it's an acute myocardial infarction. And they're just talking about the segments on the EKG, the segment titled ST. That means that ST segment is elevated. And often that denotes an infarction. Great job, everyone. So everybody said that the chief reason for the encounter was acute myocardial infarction, specifically the acute anterior wall STEMI. Outstanding. All right, so I think we can use this same list, right, and determine what is our secondary. What are our secondary codes? What is codable? Go ahead, just write it in chat. You can just put one in there as a group. We're going to code this out. So look at these items and see if it's codable or not. Good job. Lily Mae is coming through. That's right, Miss Haley. Outstanding. Hi, Miss Dolly. Hyperlipidemia. Someone saying hi. Somebody's just putting them in. I'm going to let you all just go ahead and just add to it. Good job. And they're coding it. That's what I'm talking about. But actually, I'm just asking you to name what should be first listed, right? Okay. Good job. Good job. All right. So we know that the first listed code is acute anterior wall STEMI, right? And it says it right here. Now we're going to the secondary diagnoses, and we need to know which codes coexist at the time of the encounter, which diagnoses, right? So the substernal chest pain radiating is integral, right? It's integral to the acute AMI. Now, we don't code things that are integral or related to a diagnosis on this chart. So is nausea related to AMI? Diaphoresis, that's excessive sweating, that's related to an AMI. Shortness of breath is also. Now, hypertension, hyperlipidemia, type 2 diabetes, and they are flying in the chat. You all are saying it all. And I also included history of smoking, right? Anybody know why I included history of smoking? Yeah, I included history of smoking because smoking could be pertinent to this encounter. That history of smoking could be relevant, right? Okay, so these are my secondary diagnoses. Don't consider the acute myocardial. These four are my secondary diagnoses, and I'm going to go ahead and select them in my list because these are my multiple choices. So the multiple choices that we have are essential hypertension, checking it off, diabetes type 2, checking it off, hyperlipidemia, checking it off. Now we have nicotine dependence, cigarettes, uncomplicated. Well, you know what? I'm not. I'm not going to check. I'm not going to code this because this patient doesn't currently have a nicotine dependence. No. So we're not going to code it, but I will code the personal history of nicotine dependence. It's a history. That means it's in the past, right? Personal history is a past history for that person. Also, I'm not going to code nausea or shortness of breath, as we said before, because they are related to one or more diagnoses on this list. So we're going to get rid of it. And we're only going to be able to code 4 from these multiple select options. All right, coders, are you with me? Now we got to determine what are the procedures. What are the procedures that are codable? Go ahead. Type your answers in the chat. And we're not just coding procedures per se for facilities. You're coding procedures and services. And some could be right and some may not, but go ahead and type it in the chat. Good job. Somebody said EKG. Good job, Nurhan. Yes, someone said all of the tests. Okay, you got to name the test because we got to code it. So, which tests? And you're right. I'll just say them. You don't have to if you don't want to. So, EKG, all of the tests. Anything else? Good job, good job, good job. All right, so this is what we have. This is what I have, and tell me if you agree or not. We have EKG, those cardiac enzymes, the troponin CKMB, the CBC, the CMP, the chest x ray. We'd also code oxygen in the IV fluids, right? That injection. Yeah, so this is an injection or an injectable, like an infusion is also considered. And oxygen is in the HCPCS level 2 manual. Someone said, are you coding the cardiac monitoring? No, I believe that's equipment, the monitoring, and remember, we are coding for the facility, right? So we would definitely code for their supplies too, right? Yeah, so the oxygen, very good. Now, somebody did say cardiac cath, but did the cardiac cath happen in the ED? Did it happen in the ED? Let me give you a little, oh, let's go back. It says admitted emergently for cardiac cath. And typically, cardiac cath is not going to be carried out in the ED unless it is extraordinarily emergent. They're going to escort that patient to the cardiac lab or OR, etc. All right, so these are our multiple select from our homework. And if you didn't realize, this was our homework question from last time. So this is all they gave us. And this is, oh, where am I? Okay, so I'm missing some, but it's not in our list. My oxygen and what was that other thing? It was oxygen and IV. All right, so let's look and see what we can code. If this were an exam, we would code the electrocardiogram interpretation and report. And coders, look, this 93010 is coding for the facility, the whole thing. They get the entire global code. Also, the chest x-ray 71045. That they would get the whole code. There's no professional component on it, right? Because we're coding for the facility. Also, we can code for the comprehensive metabolic panel, the CMP. We can code for the troponin quantitative. We can code for that. We cannot code for the rhythm strip because that didn't take place. And this left heart cath, no, it did not happen in the ED. We got to stay focused. So if this were a multiple select exam, we would only code the codable options from your answer list. That's it. And if there are no options, then you would select none, and none would be there. All right. So you all with me? Anybody see anything else on this list that we may have forgotten? I know people said monitoring. That's going to probably be a part of the facility, or maybe not. Maybe we do code it. Somebody said aspirin. Well, these are the procedures and services. So aspirin wouldn't fall under there. Okay. But cardiac cath did not take place in the ED. Now it is time for us to do the next step. We got to get the E&M code so that we can code for the facility. And we need to know, is this a, we have to score the problems, the data, and the risk. So we need to know what is the problem, what is the data, and what are or is the risk. Now we're going to use this AMCI PDR chart to go ahead and score it. So you can see that we have a high problem. It's pretty obvious that it's a high problem because this is an acute myocardial infarction and it falls under high because it's one acute or chronic illness or injury that poses a threat to life or bodily function, right? So it is high. So before I turn the slide, does anybody want to take a stab at the problems? And that's going to take you a moment to do it. Anybody want to guess what the problem is? So you don't have to figure it out here, but you can tell me, do you think it's low, moderate, or high? And if you know why, then tell me. Miss Dolly, she's thinking. Mmm, good job. Good job. A lot of you are saying it's high, right? Yeah, it is high, but I'm going to show you how to know if it's high, right? Yeah, I know you meant high. I do. Okay, so the reason it's high because there were 5 tests ordered and the physician consulted with another doctor in cardiology. Both of these. And if you look in the data, right? You look under data, it says, hey, you have to meet 2 out of the 3 categories. There you got category 1, category 2, and category 3. We meet 2 of the 3 categories. The provider ordered 5 unique tests when he really has to only order a minimum of 3, right? So 5 unique tests were ordered, and also this provider discussed patient management with cardiology. So it is high. See, it's high. We're in the high level. And this is where the tests are, and this is where the patient's doctor consulted with the cardiologist, and the decision was to go to the cardiac cath lab. Yeah. So we're only analyzing the data. We already established the problem, the diagnosis, that heart attack falls under high. See, the problem goes here, and now we're only accessing or that we're assessing the data. Now we're going to assess the risk of complication, and then they give us some examples, right? Anybody want to kind of guess what the risk of morbidity is, the risk of complications due to treatment? Anybody want to take a guess? Go ahead, type it in the chat. Good guess. Good guesses. Yes, this patient was admitted for surgery, and it falls right here under high, a decision regarding emergency major surgery. And for those of you that are new here, I only am showing the high portion of the PDR chart. We have a low, well, straightforward, low, moderate, and high. So I'm only showing the high because everything fell under the high category. So the decision for major surgery falls under high. A cardiac catheterization is a surgical procedure. They say it's non-invasive, but it's surgery. All right. So we don't have to do, look at this moderate data. When I first did this, this was moderate, but it did turn into high. But let's say that the data was high. Let's say the data wasn't high. Let's say the data was moderate. And I just want to demonstrate the leveling technique. All right. So we're going to use this little flub up, right? So does anyone know the leveling technique? I think a lot of you do know because we've done it several times. So yeah, we throw out the lowest and we code the next lowest. Even if I made a mistake, let's say I scored it differently, I just didn't agree because coders do have some level of subjectivity, right? So let's say I did score moderate data. Well, you know what? This leveling technique ensures that I assign the correct level, right? Because it tells you to throw out the lowest and code the next lowest. And that's still high. So we have a high level of medical decision making. So, coders, I have a question for you. What would make this scenario a critical care scenario? Do you all think this is critical care? Anybody think this is a critical care or should be critical care? And my team, a couple of my teammates said, hey, I think this should be critical care. Yeah, we think it's severe enough, like, hey, this is an acute myocardial infarction. This should be critical care. However, whenever in medical coding for evaluation and management, critical care requires time being documented. There's no critical care time documented. And if there weren't any time documented, you might want to say to the provider, you can query them and ask, was there direct delivery of care for a critically ill patient, right? And if that doctor comes back and says, hey, yeah, I did provide direct delivery of care, like, then you would ask them to give you the amount of time and you can code this accordingly. But there's no time documented, no mention that the patient was critically ill. So it's not critical care. All right, so now it's time for us to go ahead and score this facility. And we've got the evaluation and management level. It's high MDM. Now let's go ahead and score our facility. We're going to use this E&M facility acuity point chart, and we need to answer the following. What are the number of meds given? What is the degree of the MDM? There it is. What are the number of tests ordered? The number of supplies used. We're going to add it up and we're going to get our level, our MDM level. Indeed, Gail, you are spot on. All right, so the number of meds given. Somebody said, hey, maybe we can code for that aspirin. Well, it's addressed here. If it's addressed on this chart, either you're going to, if it's already addressed on this chart, then, um, I'm going to process that. And I'm also walking back on something that I discussed with you all last time. Last time I said, hey, O2, we're not going to consider that medication. Absolutely, we are. We are. And I did my due diligence, and some places don't. We will. For facilities, we will. We will also code IV fluids as a medication. Yeah, it falls under there. Even though these could be supplies, it also can be medication, but we're not going to double dip, right? So we are going to consider them as medication, and that is what my research has told me. All right, so we got aspirin, we have nitroglycerin, and we have oxygen and IV fluid. So the number of meds given falls under the 10-point column, right? The degree of the MDM that we've just figured out is high. The number of tests carried out is 5. The number of supplies used is 0. And the reason it's 0 is because I counted these two as medications and you can't double dip, right? So let's go ahead and score it. I'm out of sync here, but it's okay. All right. So the number of meds given, 10. The degree of the MDM, 25. The number of tests ordered, 5. And the number of supplies, 0. All right. Now we add them up. 5 plus 10 plus 15 plus 25 is 55. So if we look for 55 on this chart, 55 falls here. So let's go back. So this is a level 4 facility. Level 4. And as you can see, level 4 is 99284. And this level 4 facility does not match the MDM, the 99285 score for the E&M code. The E&M code will be 99285 and the facility is 99284. Even though we think that, hey, this patient had a acute myocardial infarction and everything should be high, 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 but in reality, this documentation said, hey, we didn't really do too much with this patient. We pretty much stabilized the patient and sent them to cardiac cath. All right, you all with me? Let's go back. All right. So if we had this scenario on the CCS exam, this is how you would have coded it. Number 1, you would code your first listed code, STEMI, involving the anterior wall. Number 2, you would have gotten rid of your nicotine dependence, your nausea, and your vomiting. Number three, you would have coded for the EKG, the chest X-ray, the CMP, and your enzymes, troponin. You would have gotten rid of E and F. And for your evaluation and management code, you would have coded it. Why is it? Okay, this is correct. For your E&M code, you would have coded 99285. This is high MDM, 99285. And sorry about this facility down here. It's trying to be on 99284, your level 4 facility. Okay, are you all with me? Now, how does this apply in the real world? How does it apply? Well, you're going to have to do some billing, right? So, in other words, you're going to have to take the patient demographics, you're going to have to take ICD-10 codes, your CPT codes, and you're going to take this information and put it on the UB04 form, the one I've shown you at the beginning. And this is the billing form, the universal billing form for facilities. And sometimes they call it Form 8371. And you're also going to need to know about revenue codes. So that's what the biller does. And the biller, any biller should be able to fill this form out. If they were given this form and saying, put everything where it needs to go, they should be able to do it because they learn in their instruction what each one of these fields or form locators, what it means and what should be placed there. And there is an interactive UB04 form that is phenomenal that we use here at AMCI for our CCS students. And it's a link. No, I'm not even going to try it. I was going to try and switch over so you can see it in action, but I gave you, or I will be giving you, the links for this form and you can practice at will. So essentially, you'll be able to learn which things go in each field, and you just click on it and it tells you. So this is what it looks like. Well, here is the name. The name of the provider goes in number one and the patient goes here. But what really is pertinent to us as medical coders, this field right here, the very first one, this is your revenue code. And it tells you, enter that applicable revenue code for the services rendered. And for more information on revenue codes, refer to the National Uniform Billing Committee's UB04 Data Specification Manual. So you could do that, or you can just click on the link that I'm going to give you from CMS that gives you instruction on revenue codes. But it's a 4-character or 4-digit, they're numbers, 4-digit code, and it describes what the service is. So if it is a emergency room, if we're coding for an emergency room, there is a specific code which is 0450, and that system will read 0450 and it will say this is an emergency room. um, it will, I guess, process it appropriately, right? So they're basically billing codes. Also, in addition to this section where the revenue codes are, and I'm going to give you a demonstration, this section down here where it says 67, this is where your principal diagnosis goes. And the secondary diagnoses belong in 67A, B, C, and D. So that's where you place them. And we could have a full on discussion on this form, but my goal for today was just to kind of let you see the process all the way through. So after you do all of this coding, you give it to the biller, and the biller puts it in the computer, and the computer now assigns the revenue codes and everything. All right. But it's based on how you've coded it. And this is what it should look like. Now, this 450, for some reason, I was not able to put a zero in this field. So it should be 0450. It's an ED visit. And look, it uses your CPT code. 99285. And remember, we're coding for the facility, the date of service, the number of units, and the amount. The laboratory service, the CPT code, this is for venipuncture. This is the date of service and the amount. The radiology service, this is for your chest x-ray. This is for your date of service, your units, and your amount. Your pharmacy, the medications, right here. This is your IV, right? The EKG interpretation, your supplies, such as your IV, your oxygen, your monitor, is coded under here for $250. Now, this is how the computer system would categorize things. And you might say, well, what happened to all those other labs? Well, those other labs will be coded by the the um, the pathology and so forth. But this is the code that we actually would need the venipuncture with the stick. All right. All right. So essentially that's it. I couldn't look, this was a lot getting this on this form, but I did give you this form in your handouts. You'll get this form. You'll get um the interactive UBO4 form. And I gave you something else, which I can't remember, but you got three things. All right. So I've exceeded my 30 minutes as usual. I guess I can't do it. Maybe I'm long winded, but know this, coders. I will stay and answer your questions. But first, let me give you your homework for next time. Oh, and by the way, we are going to take off for 2 weeks. It's time for AMCI to take care of our MCDC students. This weekend, we do have boot camp. If you are a silver and gold member, we invite you to come on Saturday, 10 a.m. in Discord. All right? Saturday, 10 a.m. Discord. But here is your homework for next time. In 2 weeks, we will resume. So go ahead and just take a quick peek. And this homework will be in your handout, so you don't have to do anything. I'm just letting you know this will be the homework. This is what we'll be working on next time. And then we're going to transition to inpatient. We're going to do some inpatient scenarios. I think this might have been heavy, but I want to know what you think, right? Let me know what you think. We've got a survey that I'm going to put in the chat. And I'm also going to put your handout. Let me make sure. All right, first, I'm going to put your survey. I don't want to confuse things. So please, if you can, fill out that survey. It helps us help you. It's a real quick one. So Thank you, thank you, thank you in advance. Another thing I want to give you is I got a folder for you. In that folder, you have your homework as well as those resources in there. And this is maybe I'll just type in here and say it's homework. There you go. And if anyone has questions, let me know. Do you anyone like facility coding? And even though it's facility coding, I hope you see the benefits of just being here. If you're not a facility coder, you do have to code your diagnoses and your procedures, and you got some E&M under your belt. But the difference between the facility coders and professional coders is acuity, that acuity point chart. Yes, thank you. Thank you, Andrea. Thank you, Leslie. That's right. Britter said, "Hey, she loves facility." I think you're a lady, and please forgive me for you didn't, if you're not. And Nurhan, thank you. So this does conclude our presentation, but I want to shout out my team, Miss Dolly, Miss Mills, Miss Haley, and that's all I've seen here. But you all rocked this chat too. And I just want to say so long, Miss Brenda, Britters, Vina, Andrea, Nurhan, Leslie. You know what? I'm sorry if I missed anyone. Lily Mae, VBBZ, 2019. Love for keeps. Outstanding. Thank you so much for coming. Oh, Matthew said, hey, they love the facility coding. I know that's right. I love it too. All right, so it seems like my screen kind of, I don't know what it's doing, but it's not here. And I just want to say thank you all for coming. If you have a comment and you couldn't get it in the chat, go ahead and put your comment on that survey, please. And thank you. All right, everyone. Have a good weekend.